Hello everyone. In this lecture, I am going to teach about the iron studies. Actually, these are all the investigations that we can do in a patient with iron deficiency anemia, and we'll see how we can interpret them and what exactly they mean and how we can interpret them. So let us start with serum iron and the total iron binding capacity. So what do you mean by serum iron? So in this investigation, serum iron, we are actually measuring the transferrin bound iron. Okay, as we have discussed previously, so iron circulate in the blood by binding through the transferrin. So what is the amount of transferrin bound iron? The normal value is around 50 to 100 microgram per deciliter. Okay, so the normal serum iron or the normal transferrin bound iron is 50 to 100 microgram per deciliter. Then we'll see what is TIBC. TIBC is nothing but total iron binding capacity. So this is total iron binding capacity. This is actually an indirect measure of the transferrin. So transferrin is the iron bound protein in the bloodstream. So this total iron binding capacity is the indirect measure of transferrin. That means if you have more transferrin, there will be more capacity to bind iron. If you have less transferrin, it will have less capacity to bind iron. Okay, so it's an indirect measure. So what is the normal value of TIBC? It is around 300 to 360 microgram per deciliter. So that means whatever transferrin we have in the circulation, it can bind up to 300 to 360 microgram per deciliter of iron. But how much it is actually binding? It is actually binding only 50 to 100 microgram per deciliter in a normal individual. Okay, in a normal individual, the total iron binding capacity is 300 to 360, but it is actually binding 50 to 100. So how much amount of transferrin is actually saturated with iron? So from this you can understand up to 30% of transferrin is actually saturated with iron. Okay, so that is known as the transferrin saturation of iron. So T-sat means the transferrin saturation. That means how much transferrin is saturated with iron. Okay, so from this we can understand only 30% is saturated. So normal transferrin saturation is around 30%. It is around 30%. And if you take the range, it is around 20 to 40%. Okay, so these are all important normal values that you have to remember. And so what will be the formula? It's very easy. It is serum iron by total iron binding capacity into 100. So that will be transferrin saturation. Okay. So if transferrin saturation is less than 20, it suggests iron deficiency anemia. And if it is more than 50, it is seen in hemochromatosis. So that is the disease in which you can see iron overload. Okay. So this is about the serum iron, total iron binding capacity, and the transferrin saturation of the iron. Now I will study about the serum ferritin. Okay. So it's a very important marker that we do in patients with iron deficiency anemia. So what is serum ferritin? So as I have told you previously, ferritin is the storage form of iron, and predominantly they are stored in the macrophages. And sometimes this stored ferritin from the macrophages can come into circulation, and they are actually the markers of total iron stores in the body. They are markers of total body iron stores. Okay, so ferritin is nothing but apoferritin plus the ferric molecule. Okay, so as I told, it's a marker of total body iron store. So 1 microgram per liter of ferritin means it suggests 8 to 10 milligram of tissue iron stores. Okay, so 1 microgram per liter of ferritin is equivalent to 8 to 10 milligram of tissue iron stores. Okay, so what is the normal value? Normal value in a male, it is around 100 microgram per liter, or you can also write it in the form of nanogram per ml. So microgram per liter is equal to nanogram per ml. So either 100 microgram per liter or 100 nanogram per ml. In females, it is around 30 microgram per liter. So these are the normal values of serum ferritin. Okay, and 1 microgram per liter of ferritin conveys that there is around 8 to 10 milligram of tissue iron stores. Okay, and value of less than 15 microgram per liter is suggestive of iron deficiency anemia under normal steady circumstances. Okay, under normal steady circumstances, less than 15 is suggestive of IDA. Why I am telling this normal steady circumstance? Because serum ferritin is also a acute phase reactant. This is also a acute phase reactant. That means whenever there is inflammation, so acute phase reactant means, acute phase reactants can be of positive or negative. Ferritin is a positive acute phase reactant. That means levels of ferritin will increase in presence of inflammation. Okay, so in presence of inflammation, the level of ferritin will increase. So that is why if the patient has chronic inflammation, for example, in patients with chronic kidney disease. So in patients with chronic inflammation, the targets for iron deficiency is slightly higher. So in patients with chronic inflammation, ferritin, if ferritin is less than 100 plus transferrin saturation of less than 20, this suggests iron deficiency anemia. We'll discuss about anemia of chronic disease, which is usually seen in patients with chronic inflammation. In those conditions, those patients can also, along with anemia of chronic disease, they can also have iron deficiency anemia. And how can you diagnose iron deficiency anemia in those patients? Okay, in those patients, ferritin will be elevated. So it is difficult to identify. It is difficult to diagnose iron deficiency anemia in those patients. That is why we take a combination of serum ferritin and transferrin saturation. So in those patients, ferritin, if ferritin is less than 100, along with transferrin saturation of less than 20%, that is suggestive of iron deficiency anemia. Okay, they can also have anemia of chronic disease, but if they have these values, that is suggestive of concomitant iron deficiency anemia. Okay, one more point if you want to remember, in pregnancy, the cutoff is slightly higher. In pregnancy, if it is less than 30, that is suggestive of iron deficiency anemia. You have to treat them for iron deficiency anemia. Okay, so this is about the serum ferritin. Now we'll see how the serum ferritin, how the serum ferritin and the transferrin are actually regulated. So regulation of ferritin and transferrin. Now, if you see, this is a cell. Inside the cell, you have a mRNA for ferritin. You have mRNA for the transferrin and the transferrin receptor. You can see they have a 5' and a 3' end. In the ferritin mRNA, at the 5' end, you can see there is a IRE. IRE is iron response element. Okay. So I'll just write here, IRE is iron response element. And IRP, this is IRP. IRP is iron regulatory protein. Okay, iron response element and iron regulatory protein. So what happens whenever the body has less iron level, whenever we have low iron level, these iron regulatory proteins can actually bind to the iron response elements. In case of ferritin mRNA, the iron response element is present in the 5' end. And whenever these iron regulatory proteins are binding to this iron response elements in the ferritin mRNA, at the 5' end, they can actually inhibit the transcription of this mRNA. Okay. So I hope you are able to understand. Whenever there is low iron level, the iron IRPs can actually bind to IREs. Okay. In case of ferritin mRNA, the IRPs will bind to IREs which are present in the 5' end, and if they bind to these IREs, there will be inhibition of the transcription of the ferritin mRNA. That means it will cause decreased ferritin production. Decreased ferritin, or you can say decreased apoferritin production. Okay. But if the IRPs bind to IRE of transferrin mRNA, they will cause increase in the transcription of the, increase in the translation of the transferrin mRNA. So that means there will be increased production of transferrin and the transferrin receptors. Okay. So this concept is clear. I will tell you why this is happening, but as of now you understand, whenever the iron level inside the body is low, this is actually cellular regulation of ferritin and transferrin. So whenever there is iron level is low inside the cell, the IRPs can bind to IREs, and when they bind in the ferritin mRNA, they will cause reduced translation of the ferritin mRNA. So that will cause reduction in the ferritin level. But when the IRPs bind to IRE of transferrin mRNA, that will cause increased transferrin and transferrin receptors. So why this is happening? Because whenever the iron level inside the cell is low, now the cell wants more and more iron. So from where it can take up the iron? It will take up the iron from the circulation. How can it take from the circulation? By increasing the transferrin receptors, and also by increasing the transferrin, it can actually take up the iron from the duodenal epithelial cells through the absorption, and also it can take up the iron which can be released from the macrophages. Okay, as we have discussed previously, macrophages can release iron whenever there is a need, and also iron is absorbed in the duodenum. All those iron that is coming into the circulation, these are bound to the transferrin. So in this process, whenever the cellular iron level is low, they will increase the transferrin and transferrin receptor so that more and more iron can be taken up from those areas into the cells. And also they will reduce the ferritin so that the storage fund can be reduced, and whatever iron is coming into the cell, that can be used for various purposes. So this is what happens whenever there is a low iron level. So ferritins will reduce and the transferrin and transfer receptors will increase. Okay. So from this you can understand why in iron deficiency anemia we will have a low serum ferritin. So in IDA, you are going to get low ferritin and you are going to have increased transferrin and transferrin receptor. Increased transferrin means increase in TIBC, increase in total iron binding capacity. As I told you, total iron binding capacity is a marker of, it's a marker of transferrin levels. So this TIBC, this will increase in patients with iron deficiency anemia, Okay, and the ferritin will be low in patients with iron deficiency anemia. Okay, this point you remember, we'll discuss it later. The transferrin receptors. Okay, this we'll discuss later. Okay, this is how at the cellular level ferritin and transferrins are regulated. And the exactly opposite thing happens whenever there is a high iron level. So whenever you have high iron level inside the cell, the ferritins will increase and the transferrin and transferrin receptors will be reduced. Okay. Now, other investigation that we can do is bone marrow iron stores. Previously, I mean, even in some textbooks it is written that to diagnose iron deficiency anemia, the gold standard investigation is bone marrow iron stores. However, we do not do this investigation just to diagnose the iron deficiency anemia, because it can be diagnosed with the help of simple blood investigations like serum ferritin and the transferrin saturation or the total iron binding capacities. But for the sake of completion, we can also do this bone marrow iron stores. As I have told you previously, you can, in the bone marrow smears, you can do the pulse crescent blue stain and you can identify the normal sideroblasts. What are normal sideroblasts? The developing erythroblasts, which are containing the hemosiderin molecules. And I have told you up to 30% of the developing sideroblasts will have this hemosiderin pigment. So normal sideroblast amount is up to 30%. And in iron deficiency anemia, these levels will reduce. Okay. The next one is red blood cell protoporphyrin level. As we discussed previously in heme synthesis, what is the last type of heme synthesis? Protoporphyrin 9. This is protoporphyrin 9. Protoporphyrin 9 will bind to the iron molecule with the help of this enzyme ferrochelatase, and they will make the heme. They'll make the heme. So if in iron deficiency anemia, if we do not have this iron molecule, the levels of protoporphyrin will increase. The levels of protoporphyrin will increase. Normally, it is around normally the red cell protoporphyrin level is less than 30 microgram per deciliter. However, in iron deficiency anemia, this will be more than 100 microgram per deciliter. Okay. Again, this investigation is not commonly done because we have other markers with which you can easily diagnose iron deficiency anemia. Okay. And one more point I wanted to tell is, it's a very important question. In which other condition we are going to have high RBC protoporphyrin level? So we have discussed previously that in lead poisoning, what happens? This lead can actually inhibit the ferrochelatase. And if you inhibit the ferrochelatase, this combination of protoporphyrin and iron cannot happen. Okay, this combination cannot happen. So there will be accumulation of the protoporphyrin inside the RBCs. Okay, so this red cell protoporphyrin level can be increased in iron deficiency anemia, and it is also increased in lead poisoning. It's a very important question. Okay. Now coming to some of the newer things, serum transferrin receptor protein. We have discussed previously that transferrin receptors are usually present in the cell surface. Okay, so this is the transferrin receptors. But sometimes whenever there is increased production of transferrin receptors, some of these receptors actually can go into the circulation. And this transferrin receptor, which is present in the circulation, this is known as soluble transferrin receptor protein. And this can actually be measured. And we have discussed previously that whenever there is reduction in cellular iron level, For example, in patients with iron deficiency anemia, there will be increase in transferrin and also there is increased production of transferrin receptors. Okay, so in patients with iron deficiency anemia, this soluble transferrin receptor protein is increased in the serum. So normal value is 4 to 9. These numbers are not important, okay? But just remember the concept is these are increased in patients with iron deficiency anemia. Okay, so soluble serum transferrin receptor proteins are increased in iron deficiency anemia. There is a very important index, very important index. This can be asked in the exam. It's a very beautiful marker to differentiate iron deficiency anemia and anemia of chronic disease. Okay, iron deficiency anemia and anemia of chronic disease. How? So what is this index? This is nothing but a ratio of soluble transferrin receptor protein and ferritin. Actually, it's a log ferritin, but for the sake of simplification, just remember soluble transferrin receptor upon ferritin. Okay. So what is happening in the iron deficiency anemia? In iron deficiency anemia, the soluble transferrin receptor protein is increasing and ferritin is decreasing. Okay. So this is soluble transferrin receptor protein. This is increasing in iron deficiency anemia, and the ferritin is reducing. Ferritin is reducing. So ultimately, the levels, the index will be more. Ultimately, the index will be more, and the number is more than 2. So if this index is more than 2, this is suggestive of iron deficiency anemia. It's suggestive of iron deficiency anemia. But what happens in anemia of chronic disease? Actually, in anemia of chronic disease, we'll discuss this later. There will be increase in hepcidin. Okay, there will be increase in hepcidin. And if there is increase in hepcidin, the iron cannot be released from the tissues, especially from the tissue macrophages. That means at the cellular level, we have enough iron, but those iron cannot be utilized. Okay, so at cellular level, you have enough iron. Because at the cellular level, you have enough iron, the amount of ferritin production will be reduced. So the ferritin, the ferritin will be increased and the transferrin will be reduced. Okay, so this is exactly what happens. I mean, exactly opposite of what happens in iron deficiency anemia. Okay, in anemia of chronic disease, cellular iron level is more. So that will cause increase in ferritin and reduction in the transferrin and transferrin receptors. Okay, so what happens? So transferrin receptor proteins will be reduced and the ferritin will increase. The ferritin will increase. So ultimately, the ratio will be reduced. So if it is less than 1, it is suggestive of anemia of chronic disease. Anemia of chronic disease. Okay, so this again, these numbers are important. Soluble transferrin receptor to log ferritin index is a very beautiful concept. Differentiate the iron deficiency anemia and anemia of chronic disease. Okay, now coming to the last thing. This is again a very upcoming thing. Say reticulocyte hemoglobin content. Reticulocyte hemoglobin content. Other is written as CHR or RET. This is actually the first marker of iron restricted erythropoiesis. Reticulocyte, as you know, this is the first product that you see in the circulation, first product of erythropoiesis that you see in circulation. And if you do not have iron, there will be reduction in heme, there will be reduction in the hemoglobin. So the hemoglobin content in the reticulocyte will be reduced. And this is the first marker of iron restricted erythropoiesis. And also, this is not affected by inflammation. The most commonly used marker for iron deficiency anemia is serum ferritin, which is affected by inflammation because it's an acute phase reactant. But this marker is not affected by the inflammation. And why this has gained so much popularity? Because in any patient with anemia, first we do is CBC. Okay, and in CBC, if you suspect iron deficiency anemia, if there is microcytic hypochromic RBCs, if you are suspecting iron deficiency anemia, then we will do the iron profile. But this marker, this reticulocyte hemoglobin content, can be identified. I mean, it can be seen by simply doing a CBC. I mean, not in all the instrument, but there are some auto analyzers. There are some instruments which can give this result along with the CBC. Okay, so there will be a parameter called RET, and if it is less than 27, this is actually suggestive of iron deficiency anemia. It's actually suggestive of iron deficiency anemia in the particular clinical setting. Okay, so by simply doing a CBC, we can get this parameter. Of course, if it is available, if this parameter is available, and if it is less than 27, it is suggestive of iron deficiency anemia if clinically fitting. Why I am telling it's if clinically fitting? Because the amount of hemoglobin can also be reduced in patients with thalassemia. So also these levels are reduced in patients with thalassemia, because in thalassemia, the globin chain is reduced and the hemoglobin content will be reduced. So this parameter will also be reduced in thalassemia. So in a given clinical setting, if you're suspecting iron deficiency anemia, by simply doing a CBC, if that CBC is giving this result, you can actually think of your diagnosis of iron deficiency anemia. Of course, you have to confirm with iron profile, but you can definitely think in that direction that it is most likely it is going to be iron deficiency anemia. This red hemoglobin content, it can also be measured by flow cytometry, which is denoted as percentage hypochromic RBCs or percentage hyper. Okay, the same thing, if you are identifying with the help of flow cytometry, that is known as percentage hypo. Again, it's not very important. The concept is important to understand. Okay, so this is the first marker of iron restricted erythropoiesis, not affected by inflammation, and by simply doing a CBC, which will give this red key value, can actually predict the diagnosis of iron deficiency anemia. So that is all about the iron investigations. Thank you.